Okay. A couple more torture tests and then we'll be done, okay? I promise.
All right.
Look straight ahead for me. I'm going to hit this on my knee and then I'm going to put it on your nose. And I want you to tell me if you hear it louder in the left ear or the right ear or if it's about the same.
Okay. Maybe a little louder in the right ear. Louder in the right.
Which is louder? Number 1, number 2.
2.
Number 1, number 2.
2.
2. Louder in one ear or about the same?
About the same.
About the same? Look straight ahead. Same thing with this one. Number 1, number 2.
Number 2.
2.
Much louder.
Number 1, number 2. 2. Things I don't need to ask, I can tell by your face. I'm gonna squeeze by you again. So
yeah, that's the fun with fibro. It's everything's much more sensitive.
So what we see on the CT scan is it looks like this kind of vascular, what we call a hemangioma, and it has sort of remodeled the bone sort of above your ear, kind of. So this part of the skull is called the temporal bone, and that temporal bone is sort of houses the structures of the inner ear and the middle ear, and so that's where Dr. Dunn kind of wanted my expertise in terms of helping to sort of get the tumor out from around those structures. I don't see on the MRI, and it's a little bit more difficult to tell on the MRI than it will be on the CT scan, but it's a little bit difficult to tell whether it involves the middle ear. I don't think it involves the middle ear. It doesn't look like it does. On exam, I can't see anything. It could involve the very, very top of the middle ear, and if that's the case, then we'll have to kind of delicately sort of get it off of potentially get it off of the ear bones. The other thing is it does look like it involves some of the mastoid air cells, which are kind of behind the ear.
Yeah.
But it doesn't involve the ear canal. When I look in the ear canal, like if I just looked in your ear and I didn't know you had this thing, I'd probably say it looks normal. But because I know that this thing's there, it sort of looks like the top part of the ear canal is maybe just a little bit kind of full. It just looks like it might be sagging just a little bit, but it certainly doesn't like enter the ear canal or, it doesn't involve the skin of the ear canal or anything like that. So my role, I think, in the surgery, and Dr. Dunn and I, we haven't sat down and looked at the scans together. We usually do before we do these joint surgeries, but we will. We haven't sat down, but I suspect he's going to take some kind of a what we call a transtemporal approach where he goes through this way. And from what I also understand, he is going to get, and I think that's part of what the CT scan is for, is he wants to get a prefabricated implant because he's going to have to remove some of that bone. He wants to put a prefabricated implant in there to sort of rebuild that contour of your skull where that bone is going to be missing after the surgery. And again, my role will be to drill out the mastoid bone, any of that bone of the mastoid, and also help to get the tumor off of those the middle ear bones and up out of the middle ear if it does involve it. Like I said, though, it certainly doesn't look like on exam that it involves it, but it's a little bit difficult to tell. But the CT scan will help me in that regard. So that's why I definitely want to add some special cuts onto the CT scan.
Of course. And I believe the CT scan is this week. That's when it's been scheduled for.
Okay. And your hearing, the reason I asked about your hearing is some people can feel like they have a hearing loss even though even though they don't. And your hearing is normal in both ears. It looks good. So your hearing is normal. Okay, so you brought some of the Mayo clips.
The Mayo results. Yeah. I sent those over.
Perfect. Yeah, that'll be
that way you have a baseline.
Yeah, that'll be helpful to look at. Do you have any questions for me, or what questions of yours can I try to answer for you?
think you've already answered a lot of mine.
Yeah.
Have I?
Yeah.
Well, that was easy. Yeah, I mean, if you think of anything, please write it down. I always see my patients before we go back to the operating room, so you can always ask me kind of last minute things.
Mm-hmm.
Dr. Dunn, do you have a follow up with Dr. Dunn? Do you know?
He's supposed to be giving us a call. We were going to have a 9 a.m. meeting with him right before this, but I think he has surgery. So he's supposed to give us a call and go over the results of the MRI.
Okay. Oh, so you haven't, because I think it was just on the 22nd, which is like last Thursday.
Yeah.
Okay, so you haven't had a chance to talk to him after that was done then?
Not yet.
Okay. So he was looking at, that's right, he was just looking at the CT scan.
Uh-huh.
That's right.
The original CT scan.
Well, I'm not surprised the resident ran off with the CD. When we were at that meeting with Dr. Tawana, I told him that I've been telling Nicole she's going to be a case study. He just kind of grinned.
Yeah. Well, as much as I am in education and educating others, it's a good fit.
Yeah.
If you've got to have a tumor, then,
have something that not everybody else has, right?
Yeah.
I need to get together with Dr. Dunn, and we'll talk a little bit more about our specific approach and the incisions and so forth. But I would imagine that you're going to have an incision that probably will start behind the ear and probably come up like this in some fashion.
Mm-hmm.
There may be, especially for the TMJ part of it, there may be some part of the incision that goes here in front of the ear.
Uh-huh.
We may actually start here in front of the ear and come up like this and sort of do like a question mark, kind of a reverse question mark kind of incision. And so it may look something like that. We'll try not to shave much hair, but sometimes we do have to shave a little bit. Usually if we do, we kind of lift, we lift up the hair and shave underneath of it. So then after surgery, the hair will fall back down and cover it up, and you won't be like, missing half your hair. And so that's usually what we try to do. The risks of surgery, just like with any surgery, bleeding, infection, the risks of the general anesthetic. Specific to my part of the procedure, there's always the risk to the ear bones, which would mean that there's a risk to the hearing. I know you've had ringing in your ears for a long time, but there's a small risk that ringing could get worse. And I don't say these things to scare you, but I just, unfortunately, anytime we do surgery, there are risks. These things happen very rarely, but I wouldn't be doing my job if I didn't tell you. So worsened ringing in the ears, worsened balance. I don't think that's going to be an issue just because we're really not going to be in and around the balance structures. As far as the intracranial part of things, that Dr. Dunn and I will kind of do together, there's always the risk of CSF leaks, a cerebral spinal fluid leak. Meningitis comes along with that, stroke, and then the bad D word, right? Death, right? This tumor does not really involve the brain. It's not in the brain, it's sort of on top of the brain and kind of pushing it. So we're not going to really be in the brain, the substance of the brain. We're going to sort of be on the outside of it. So that a lot of those risks don't super apply to you. But again, I wouldn't be doing my job unless I told you.
Well, I guess one thing that was one of the reasons I guess that Dr. Dunn wanted to do the MRI just to verify that it wasn't somehow tapping into the actual brain. I'm guessing it doesn't look like it.
I think I had the advantage. I haven't seen the CT scan, but I have seen the MRI. So I was able to look at the MRI, and on the MRI, it doesn't look like it goes into the brain. Sort of kind of on the outside. So we got that going for us. The risk that, when all this heals up, that you don't like the way things look, we call that a cosmetic, less than desirable cosmetic. The way your hairstyle is, though, you honestly would never see it.
Not worried about that.
Trying to think of anything else from my standpoint. I'm kind of covering a lot of Dr. Dunn's part of it too, but I think I think this is obviously sort of an unusual. Certainly isn't a straightforward kind of thing, but Dr. Dunn and I are both very sort of particular, and we plan things out, and so we do a lot of cases together, and we work well together, and we kind of always have a game plan going into things, and so we'll do the same with you, and take the very best care of you we can.
Appreciate it.
Okay.
And that's exactly why we're going with the two of you.
Good. Well, thank you. I appreciate
Because we've heard really good things.
Oh, I was going to say, don't believe some of the things. Don't believe everything. The good stuff, yes, but we're both very particular, and we'll have a good game plan. And I don't know what the oral surgeon's role is going to be. I'm sure he'll be there for parts of the procedure.
Mm-hmm.
I plan on probably being there for most of it, and be there to help Dr. Dunn however he needs me to help, and do whatever we need to do. Because I think the goal of this is to get it all out.
Yes.
You know, we don't want to leave some of it behind, because if we do leave some of it behind, then there's that risk that it can come back, and so we certainly don't want to have to go back if we don't have to.
Yeah.
I will say there's an outside chance, and I say outside chance, that if we have to, again, I think this is minuscule, tiny little chance that we may have to close off the ear canal. And what I mean by that is you would no longer have an ear canal. We would close it off, so if you looked in your ear, you wouldn't see an ear canal. It would just be like a blind pouch, just skin. In order to do that, what I have to do is because I can't just close it off and then leave all this skin, right? Because then that skin will kind of proliferate and so forth. So if, again, this is an outside chance, and if when Dr. Dunn and I are talking, planning things before surgery, if I feel like it's more than a minuscule risk, I will let you know. But at this point, I think it's really a minuscule risk. But what that would involve is it would involve taking out the eardrum and the first two ear bones and closing off the ear canal. Now, what would that mean for you? You're not going to miss your ear canal, but what it would mean is that you would then have a maximal conductive hearing loss, meaning that sound normally comes in through the external ear, hits the eardrum, vibrates the three bones of hearing, and then goes to the inner ear, the hearing portion of the inner ear, and then along the hearing nerves to the brain. And if that's the case, we could always rehabilitate your hearing with something called a bone-anchored hearing aid, where we would put that little post back here behind your ear, and then what that would do is basically bypasses the whole ear canal and the ear bones, and just stimulates the inner ear directly by vibrating the bone of the skull. Again, I just say this to you because I'd rather broach the subject and have the conversation now, as opposed to the morning of surgery, or you wake up and have your ear canal closed and say, "What's up, man? Like,
why can I not hear?
You never told me about this." Or, me have to go out in the waiting room and tell you and explain to you, and then you feel bad about saying yes, do it, without having her permission. Right. I'm just I always try and plan one step beyond what I think we're going to need to do, just so that, if we come out and tell you, we did have to do that, then you're like, okay, I got you.
That's much appreciated. And I'm guessing, when you say minuscule, you're talking like, low single digits.
I'm talking like less than 1 or 2%.
Yeah.
And the only reason that I would have to do that is if the tumor has eroded this bone to the point where we can't get the tumor out without violating the skin of the ear canal, then we have to close it off, because that would mean that then essentially the brain and the cerebral spinal fluid would be communicating with the ear canal, and we obviously can't have that, right?
Yeah.
And so we would have to close that off so that it kind of encapsulates and isolates that spinal fluid space and the brain space from the outside world. Because otherwise your brain could potentially literally just hang down in your ear canal, and we don't want that.
No.
So anyway, that's an outside possibility, and unfortunately that's going to be a bit of a game time decision, but I'll be able to get a little bit better idea of that from the CT scan.
Good to know. Idea on approximate timing, like a month, 2 months?
I'm thinking hopefully maybe end of September, beginning of October.
Okay.
That's what I'm shooting for.
For the actual surgery.
For the actual surgery, yeah. And as far, if you guys had a trip planned, or you had, a big wedding to go to or something, I don't think this is an emergency. I'd say, well, let's say you had like you were in 3 weddings and you had a trip to the Bahamas planned. I'd say, well, let's wait till those are done. You know what I mean? So I don't think it's an absolute emergency kind of thing. Okay.
Awesome.
All right. we discussed the nature of your tumor today and my role in the surgery that we are doing. I will be doing in conjunction with Dr. Dunn and with oral surgery. Period. My role is primarily to work in and around the ear structures, including the mastoid and the middle ear bones, if necessary. Period. Next line, we discussed the very outside chance that we may have to close off your ear canal. Period. This would give you a maximal conductive hearing loss. Period. Next line, we discussed the risks and benefits of surgery. Period. In terms of time in the hospital, I'd probably say a day, maybe 2 days in the ICU, probably just 1 day. Then get to the floor, get you up, get you walking around, get your blood flowing. And once your pain's controlled, once you're eating and peeing, we'll get you out of there.
Is there going to be any problem with me doing medical marijuana as my pain meds?
I don't think so.
Okay. And I just wanted to make sure that,
Unfortunately, not
before
in the
surgery
hospital,
and well, yeah, kind of figured as much.
Unfortunately, but yeah, once you go home, no, I don't think, not from my standpoint.
How about before surgery? Is there any kind of contraindication?
That's a good question. I think you'll have to talk with the anesthesiologist about it because you'll probably meet with them before surgery. I think in general, they like for you to refrain from it.
Okay.
For like at least a week or two.
A week or two?
Mm-hmm.
Oh,
to get it all out of your system. Yeah. But check with them, ask them about it because they'll be able to give you sort of a more scientific answer as to why. But I think it can sort of cross over with some of the receptors that their general anesthetic and their pain medication tries to target. And so if that's the case, then it can sort of decrease the ability of those medications to work and significantly increase the dose of those medications that they have to give, and therefore can increase the side effects of the medications they have to give just because they have to give a much higher dose than would normally be needed.
Got it.
That kind of makes sense. What do you use it for right now? Primarily just the pain, the TMJ pain that you have?
The fibro pain, sleep. Okay. It's about the only way I can really sleep.
Really? Wow. So do you use it every night then or every day? Okay.
Every day.
All right. What do you take? Do you take anything else for your fibromyalgia in terms of medications or anything?
I'm on Zoloft and birth control. Those are the only two medications that I'm on right now, other than the medical marijuana. That's it.
She used to be on gabapentin.
I used to be on several things, including for trying to get me to sleep. And
there's a bunch of stuff.
Yeah, none of that other stuff worked. The gabapentin did help with the pain, but at one point we'd considered potentially having kids, and so I knew I would have to go off of that. So went ahead and got off that.
Gotcha.
And then that's when started trying the medical marijuana to see if it was of any use, and it's amazing.
Good. Well, I'm glad you found relief with that. So that, you said the Zoloft and then birth control, those are the only medications you're on?
Yes.
Okay. All right, perfect.
And another thing to bring up too, I don't know if it has actually manifested into this yet or not, but in my DNA, I do have the JAK2 mutation that my mother's mom had. Hers turned into polycythemia vera. Okay. So just wanted to get that across because I know it's a bleeding disorder and just, want to make sure everybody is aware.
Yeah, I'm just trying to remember. It's been so long since I've heard the JAK. It's JAK, I think, too. What is that? Does that have with blood dyscrasias, different hemophilias and stuff?
Yeah, she produced way too many red blood cells.
Oh, okay. So polycythemia. Okay.
Yeah.
Because we'll do blood work. We'll do blood work before surgery.
Okay.
You're right. Yeah, so polycythemia vera, just like I had said. Okay. Okay. Cool. Well, that's good to know. At least we can be on the lookout for that on your preoperative blood work.
Yes.
And I'd definitely let anesthesia know about that too. But we would see, if you had polycythemia vera, if your red blood cells were super elevated, we'd see that on a pre-op blood work. Have you ever had any indication that you've had anything
Not so far.
in that regard? Okay. Let's see. I have added a special CT scan onto the CT scan that you are already getting this week. Period. Next line, Dr. Dunn and I will discuss our surgical approach and timing for surgery, and will notify you of the surgery date. Period. Next line, follow up with Dr. Bean approximately numeral 2 weeks after surgery. Period.